All right, it's 5 o'clock, everybody. Hi, everyone. Just drop a message in the chat to say if you can hear me or not. Great, you can hear me. Good. Okay, so last week we started talking about hematemesis, and we're going to continue on that with this case. So we're going to go from gastric ulcers onto varices, and then we'll continue from there. As always, make sure you drop in answers in the chat. Any questions, put them on there as well. And if there's any issues, let me know as well. Okay. So we'll get straight in there. We've only got 40 minutes again, so we'll see how it goes and get as far through as we can. Okay. So we've gone from gastric ulcers to esophageal varices. So varices are venous congestion within the esophagus, and they're classed on their location and protrusion into the esophagus. So the location themselves is based on this diagram. So you have esophageal varices on the left-hand side here in picture A, which come down from the esophagus. You also have gastric esophageal varices, one on the left here, and then right on the top. Then you have the inferior gastric varices. And you can see their location in tune with the splenic vein here as well. So protrusion to the esophagus is based in class from 1 to 4. 1 is mild distension to the esophagus, and 4 is complete distension. So there's no possible way any food or anything that could get through the esophagus. Cool. So how do we treat the esophageal varices? Well, what we do, the first optimal treating is variceal banding. So you can see here, we band them. So when you've done your gastroscopy, looking down into the esophagus itself, you'll see them protruding, and the first thing we should treat them with is banding. So we band them off so that they wither away and don't protrude into the esophagus anymore. After this, if it's not being treated by banding, what you normally do is perform a TIPS, which is a transjugular intrahepatic portosystemic shunt. That's what you should do next if it's not being treated by this variceal banding, but you managed to control it on the first occasion. If on the first occasion you go in, have the look for the OGD, and it's major hemorrhage, what you'd rather do is, if you can't treat with banding to begin with, and the patient is bleeding out in front of you, what you should really do is go for the Sengstaken Blakemore tube. So this is what it is. So it's like a balloon that you put down to the esophagus, inflate it, and it should, through the pressure, stop it from bleeding anymore. So how do we treat that pharmacologically? So to begin with, we can give terlipressin 2 milligrams IV 4 hourly for a maximum up to 5 days. This also can be octreotide, but we always use terlipressin in hospital. And how it works is by causing splanchnic vasoconstriction. So there's a little diagram here. Can you all see that? I've had to draw on this lower gastric vein. So what you do is, by giving the terlipressin, you're decreasing the pressure in the splenic artery, which decreases in turn the pressure in the splenic vein, and therefore decreases the pressure in the esophageal varices, in the veins in the esophagus, as you can see on here. So you're getting lower pressures in that area, so you're less likely to bleed into the esophagus. You also give patients 7 days of prophylactic ceftriaxone. All these patients have underlying, well, most of them have underlying hepatic disease, so they're at high risk of this gram-negative infections. It's what ceftriaxone is. And actually, as well as decreasing the gram-negative infections, it also decreases the risk of rebleeding. I'm not sure how it works, but it's a helpful side effect. In the last slide, you probably saw the Child-Pugh scoring, and that will tailor the treatment for these patients, but that's more to do with gastro medicine than it is to do with surgery. So I'm not going to go too in depth into that in this lecture. But if anyone has any questions about it, you can feel free to email me or do a bit of reading as well. And then the primary prophylaxis after these variceal events, or if patients, you do an OGD beforehand and they look like they've got varices, haven't bled, you put them on beta blockers, propranolol, 40 milligram bi-daily, and that's indefinitely. And that's just to decrease the pressure in the veins themselves. Cool. Oh, so got a question. So in the last lecture slide, we talked about the TIPS procedure. What's one major side effect of TIPS? Yeah. Okay, so you get hepatic encephalopathy. And what's the mechanism behind this? It might be quite a long thing to type into the chat, so maybe I'll just talk through it. So in the procedure itself, basically you produce a shunt so that the blood, so the blood doesn't go through the liver anymore. So this ammonia isn't broken down by the liver on its first pass through its absorption. So the ammonia crosses the blood-brain barrier, as Chris says, big kudos to Chris, passes through the blood-brain barrier and then leads to this encephalopathy. What's the management we normally give to patients who show this hepatic encephalopathy, or as a prophylaxis before they get to this point? People asking Chris to put some more answers in. Okay, yeah, so we've got a few answers. Laxatives, lactulose. Yeah, so lactulose is what we give patients medication-wise, just to increase the speed that food goes through the gut so it doesn't absorb much ammonia. And we also put them on a low-protein diet as well to stop ammonia being formed. Cool. So bleeding risk. So you would have thought in this scenario, the patient is bleeding out, and you think that you surely must stop anticoagulants during these bleeding events. But it's a difficult one because a lot of patients with like peptic ulcers around maybe the 50, 70 ages, they might also have underlying comorbidities as well, like heart problems, might have previous TIAs, that kind of thing. So actually during these events, the highest morbidity is actually due to underlying comorbidities. So the pressure of bleeding leads them to die from these other comorbidities. So patients who are on aspirin for maybe they've had a stroke before should continue taking aspirin, but patients should stop NSAIDs. And then if taking clopidogrel or other antithrombotic drugs, you should use the HAD-BLED score, the CHA2DS2-VASc score, to weigh up whether it's worth continuing them during this bleeding event or to stop them. And then other antithrombotic drugs for heart disease, things like that, you would probably stop during those events and then restart as early as possible after stabilization. Because within the next 1 or 2 days, these patients haven't been on these antithrombotics, and they're likely to have cardiac events. Okay, let's break for some questions. So Fraser said last week he did a quiz on, was it Kahoot or something? So I think you all enjoyed that. You can tell me if you did or didn't in the chat. But we're going to do a quick one as well on here to see how you find it. Oh, much better. Much better. Nice. Good round, good round. All right, that's a nice little warm up. Well done to Emilius. Fastest one on there. Oh, I only got, on the same time, 3 people. Nice one. Let's see how the scores go at the end. Just get this one. We just talked about this one. Oh, that was quick. Nice. A lot of people getting banding. Ooh, Emilius still at the top. That's quite exciting, actually, isn't it? This is a question from last week. Taking a bit longer this time. Nice, most people getting this one. So omeprazole is given. So last week talked about this, and I have a clarification to make from this actually. So in the Merseyside guidelines, it's 80 milligrams initially start IV. So it's 80 milligrams start IV, and then 8 milligrams per hour for 72 hours. Okay. Still at the top. Is somebody going to get Amelius? Oh, tricky one. How fast can you Google this? Oh, split down the middle. This is a little bit of last minute revision before finals. Get the inhibitors and inducers in. Oh, Amelia's still at the top. Tricky. Ah, nice. Okay, so most people getting this one right. So from last lecture, we talked about peptic ulcer treatment. So can anybody drop in the chat what kind of treatments we offered for peptic ulcers? No? Okay, that's fine. We're going to the next question. So you can't use adrenaline injection at home, so you need to be done with something else at the same time. So the adrenaline injection can't be used on its own for treatment. Yeah, so you use clips and adrenaline, or you can use sclerotherapy and adrenaline. Ooh. Amelia's still on top. Don't look at the chat, everyone. Okay, most people got that right. If you looked at the chat, you would have been handed the answer there. So we use Glasgow Blackford score for pre-endoscopic treatment, for looking at pre-endoscopic. So it's risk stratification, whether they're going to need admission or they can be sent home. If you get a score of 0, you can be sent home, basically. You don't need treatment. If you get a score of 6 and above, you've got a 50% chance of mortality. And then the Rockall score will guide you to what treatment and what the prognosis probably is. Oh, we got a movement. Jess is on top. Ooh. Last question. So we just been through this in the lecture. So propranolol 40 milligrams is given to patients for primary prophylaxis for esophageal varices. It's just one you have to learn, really. Let's have a look who on top of the podium. Weldon to Essex, 3rd place. Come on, classic name. And well done everybody else. Now I'll close this. New share. PowerPoint. Okay, we back on the PowerPoint. Can everyone see that? Okay, so the answers are on here as well. All right, we're going to discuss other causes of esophageal bleeding. So other differentials. Everyone here? Okay, cool, good. Thanks. So we're going to talk about other differentials for esophageal bleeding. So Malleus tear. So how this comes about is, okay, so that's a picture there. So it's just these slight tears at the esophageal gastric junction, normally caused by like vomiting. There we go, acute tears, gastroesophageal junction. So the risk factors, anything makes you vomit more. So things like in pregnancy, when like women have been sick quite a lot during the first trimester, or alcoholism, being quite sick there, or anything that makes you vomit more. So the risk factors. Investigation. So as before, so we've got to exclude other pathology. So we'd have to do an OGD to exclude other pathology. A lot of the time, you can't actually see Malleus tears on an OGD because they're quite small. So if you don't really see anything on an OGD, you can, and there's a history of lots of vomiting before hematemesis, then you can look at Malleus tear. So the treatment for Malleus tear is quite simple. Most people recover spontaneously because it's just like a cut, basically, the esophageal gastric junction. But there's no need for intervention. So a bit of monitoring for the signs of rebleeding and an easy discharge. Esophagitis. So we're going to move on from the causes of bleeding in the esophagus to causes of inflammation. So esophagitis is the word that means inflammation in the intraluminal epithelial layer of the esophagus. It can be caused by a lot of things, but most commonly it's caused by GORD. I'm going to talk about that in a bit more detail a bit further on. So other causes include like fungal infections, taking bisphosphonates, radiotherapy, or toxic substances. So GORD, risk factors, quite simple: obesity, old age, hiatus hernias, or medications that cause reflux, or things like NSAIDs. First test for is H. pylori. We discussed this last lecture about H. pylori, so you can watch it on the YouTube channel if you want to catch up. And this is basically, GORD is diagnosed by a trial of PPI for 8 weeks. If it settles down after 8 weeks by taking PPI, you basically diagnose what GORD itself. And you start normally with meprazole 20 milligrams. So H. pylori testing isn't routine in GORD. Okay. No, but you would normally test for H. pylori as a cause for esophageal reflux and these symptoms first. And if it's negative, then you would trial for PPI for 8 weeks. And then the diagnosis would be for GORD. Cool. No worries, Chris. And the trial is you start with 20 milligrams of meprazole once daily. So what red flag symptoms will we have to use an OGD for? So this is really important. So if a patient presents with reflux and they're age over 55, more than likely you're going to find one of these other symptoms as well. They're going to have upper abdominal pain or reflux and potentially weight loss. So they'll be sent with a 2-week referral for an OGD. Non-urgent referral is for patients 55 plus with treatment-resistant dyspepsia. So you have the 8 weeks of PPI, and then the patient still has dyspepsia. They'll go for non-urgent referral for an OGD. And then other symptoms such as upper abdominal pain plus anemia would be non-referral. And then the other ones as well that you probably see in CCT already. So you probably know all these quite well. Okay. So Barrett's esophagus. We're going to discuss Barrett's esophagus, and then we're going to move into esophageal cancer. So Barrett's esophagus is defined as a metaplasia of squamous cells to columnar cells in response to esophageal damage. And this damage is normally caused by untreated GORD or things like smoking or obesity, like high-fat diets that causes reflux. And the typical patient is like an older, obese white male. And the presentation is you normally get a presentation either with resistant dyspepsia or rarely dysphagia, and that will guide what the investigation is. Because the patient presents to you with dyspepsia, you're going to give them an OGD because they've got this resistant dyspepsia, and you're going to see the Barrett's esophagus on the OGD itself. And when you see the Barrett's esophagus, you take a biopsy to see how dysplastic the area is as well. And then if the patient presents with inability to swallow, then you would send them for a barium esophagogram to determine the site of stricture. And if there was no obvious stricture there, then they'd probably perform an OGD again, and then you'd see that was Barrett's esophagus. This is what it looks like. You can see the metaplasia. So normally this pinkish should be further down at the, you see the stricture here at the lower esophageal sphincter. It's moved up. Okay, let's determine what dysplasia is. So dysplasia is when cells don't differentiate as well, and they have like an undifferentiated nucleus. So you see there's normal, well-lineated cells here, mild dysplasia, and then you can see the difference between the moderate and severe dysplasia. You can see the nucleus of cells are much larger, and they're not as well arranged. And this is where you lead to cancers. So what's the treatment for Barrett's esophagus? Well, if it's non-dysplastic, there's not much to worry about really. So you just take omeprazole 20 milligrams OD, because mostly the patients present with the GORD. So this is basically what the treatment would be for GORD. And then 2 yearly endoscopy to make sure it's not becoming more dysplastic, and take another biopsy. If it's low grade, you can have radiofrequency ablation, so ablate the flat lesions, or if it's like a nodule itself, you can just resect the nodule, and then yearly endoscopy to make sure there's nothing coming back. And if it's high grade, so it's the same as the low grade. You can ablate the high grade area, or you can resect it and then give a PPI. But then after that, because it's quite high risk of patients having early stage adenocarcinoma, you can also offer the patient esophagectomy, so remove that part of the esophagus. Okay, so we'll move on to esophageal carcinoma. So the two types, adenocarcinoma and squamous cell carcinoma. So the risk factors in adenocarcinoma, this is what comes from Barrett's esophagus. So the risk factors are GORD and anything that causes Barrett's esophagus. So as we said before, high BMI, high fat intake, usually a white male. So this is the risk factors for adenocarcinoma. White male, high fat intake. And then squamous cell carcinoma, we have, these are the three main risk factors basically. If you get any history with HPV or high smoking with inability to swallow, it's more than likely going to be squamous cell carcinoma in the esophagus. Smoking increases it from 3 to 7-fold, which is quite high risk ratio. There's the risk factors of squamous cell carcinoma. Oh, this is a little bit of a quiz, isn't it? I forgot about this slide. So we talked about red flag symptoms for patients with dysphagia. What are the most common ones that would come up? Yeah, weight loss, very important. Yeah. I think there's 3 here. So will painful swallow? Yeah. So what's the name for painful swallow? Adonophagia. Nice. Hoarse voice. Yep, that's a good one. Difficulty to swallow food and liquid. Yep. So you get an increasing obstruction in the lumen, so it's going to be harder to swallow food and then liquid as it gets bigger. So of this dysphagia itself, adonophagia, which is the painfulness, weight loss, hoarseness of voice. Okay. And then it's, as we said, it's important to explore all the risk factors for patients with cancer. So how do we investigate cancer? So with the 2-week wait rule and if patients have weight loss or odonophagia, dysphagia, they sent for an OGD, and then you take the biopsy to distinguish what the cell type is and the dysplasia present. What we do after that is normally you can do a CT chest and abdomen to see the extent of the invasion in the esophagus and in the abdomen. But common practice now is you can actually do a full body CT, depending on how the risk benefits to the patient of providing them with that radiation. A lot of patients now do have a CT of the whole body. So you want to see the local invasion and the presence of metastases like in the liver, most commonly. An alternative to this is MRI chest and abdomen if patients can't have a CT scan. And then we perform a PET scan for metastases, which most commonly in the liver because of the venous flow. And then we can perform endoscopic ultrasound with fine needle aspiration. So this is to see in the area how locally invasive it is with the fine aspiration. And then also we aspirate the surrounding lymph nodes to see the presence of cancerous cells. And this will help us to determine what TNM stage the cancer is. So the three aspects of esophageal cancer, so we have OGD, so scope, then we have CT chest and abdomen, or MRI chest and abdomen, which is scan, and then we have the PET scan and slide, which is taking these needle aspirations, looking at the slides, looking at how invasive they are, and if you have any lymph node cancerous cells. And then surgery as well. So potentially, instead of doing the endoscopic ultrasound and fine aspiration, we can also do laparoscopic surgery to visualize the cancer itself in the esophagus and fine needle aspirate in this surgery. So surgery is an alternative for this slide, but for esophageal cancer, it's only scope, scan, slide. So you can see here what the TNM stage is for esophageal cancer. It's quite similar to gastric cancers in that it's to do with how far through the lumen it is. So T1 is normally up to the submucosa, T2 up to the initial first half of the muscle, T3 is protruding all the way through to the adventitia, and then T4 is into like local areas, so like the aorta, or it can be into other local structures like the trachea. Did it come up in my exams? No, it didn't. But I think the most common one that comes up in exams is Duke's normally. So like colon cancer. I'm trying to think if there's a TNM. It's the other one that come up quite often is TNM staging for things like bladder cancer, because that does affect the outcome of treatment quite often. This one will as well. So you need to know it quite generally because the TNM staging does significantly change the outcome of patients with esophageal cancer. That's right. So here's the TNM stages. So I'm just going to talk about the general gist of the TNM stages and how we put them into. Do they use Dukes in the UK? Yeah, they still talk about it. Like older surgeons talk about it quite a lot, but it's more TNM staging now. TNM staging is used by NICE, but I think Dukes is what some surgeons still refer to. If that helps, Danny. So TNM stages, so the stage 1 using TNM is generally just a cancer which protrudes into T1 level. No nodes, there's no metastases, it's just a T1. Stage 2, you can either have T2 invasion or you have 1 or 2 nodes of lymph nodes. So you can have a T1 or T0 with 1 or 2 lymph nodes. And that'll be at stage 2. Stage 3 is generally 3 to 6 nodes. So you can have any T stage and 3 to 6 nodes, or it would be a T4 invasion, so an invasion into like the aorta trachea as we talked about earlier. And then stage 4 is any metastases. So any stage of T, any stage of N, but there are metastases present. Because once it metastasizes, esophageal cancer is quite lethal. Okay, so we just go for the treatment slide now. And I think that's probably going to be the 40 minutes up actually after this. And then we'll kind of a quick chat about what you want from future lectures and things like that. So the treatment for stage 1A, so just endoscopic mucosal resection. So you just take away the stage 1 cancer because it's very shallow within the lumen. You can just take it away. 1B or 2A, radical resection. So you would take away quite a large lump of the esophagus, quite a large margin to make sure you've removed all the cancer. Or if patients aren't really up for surgery, like older patients or patients with other comorbidities, you can provide definitive chemotherapy. So chemotherapy can actually treat these patients at stage 1, 1B or 2A. But it's very rare to actually find patients with stage 1 or stage 2 esophageal cancer because you don't have the adonophagia or the dysphagia until later on in the pathology. So stage 2B/3, there's a pre and post radiotherapy with esophagectomy. And what's the reason why we use pre and post radiotherapy? Does anybody know? Yeah, Chris, nice. So you want to try and make the tumor as small as possible before you do esophagectomy. Because when you go into surgery, you don't want to take out a massive chunk of the esophagus and surrounding tissue. You want to have as small a target as you want to cut around so we can leave as much esophagus as possible for the patient. Because surgery is quite barbaric, if you really think about it. Stage 4 is more than likely the patient's not going to do very well after this. So basically chemotherapy with the regimen of a dual therapy of fluorouracil and cisplatin. You can also test the patients for HER2. So what other cancers do we test patients for HER2 in? Yeah, breast cancer. Well done. So we can also, if they're HER2 positive, we can provide patients with trastuzumab, which is the same in breast cancer, and it works quite effectively actually. And then for patients at any stage really, we can provide them adjuvant treatment. So more commonly in stage 4 in palliative, which you might talk about in palliative when you've done if you do your block or when you've done it already. I mean, I don't think you'll be doing it now if you don't finish the year. So the adjuvant treatment you can do is basically for symptom relief, which most commonly patients can't swallow or patients have a lot of pain in their esophagus. So you can use brachytherapy to try and shrink the tumor or stent it so the patient's going to eat. And the 5-year survival is basically the extent of the spread for esophageal cancer. So if you've got stage 4 or stage 3 where you've got quite a lot of nodes, lymph nodes, the outcomes aren't very good. Okay, so that was 40 minutes. I think Fraser is trying to get the paid version so we can go on for as long as possible. How's everyone finding it? You can drop in the chat what you think about these lectures so far. That's good. Amelia is learning. So I think there's, let me have a look. So there'll be another feedback form. Quite a few people, oh, thanks, Katrin. Quite a lot of people, I think 18 people filled it in last time. Most of the comments were quite nice, which was good. One of the most important ones, I think, is just the time duration. So we're only going for 40 minutes at the minute, but I think when we get the paid premium version of Zoom, we'll try and go on for longer. But how long do you think you could concentrate for? Because I think 40 minutes is quite good to listen to. I don't know if you would be able to listen for an hour and a half or a bit longer. Hours? An hour? Yeah. Okay. So some people flittering between 40 and an hour. 50, nice in between. Yeah. I mean, I think if we get the paid version, we can try for an hour, see how people find it, and then compare it. But I'm kind of thinking about the 40-minute mark. And how did people find it with this continuous lecture? Do they like it, or would they prefer like a start-stop? Did people like the start? Okay, yeah, cool. Okay, I know it's kind of different. Normally, you have like an introduction to a topic, and then you have a bit of information, and then like a case or something, and then you have like a conclusion at the end. But yeah, I kind of think this is quite an interesting way of doing it. So you're going through a lot of subjects, and as you go on recapping. So next lecture, we'll have a recap from the first lecture and this lecture. So hopefully we'll be able to pick out facts from all of them. And if you want to recap on stuff, the videos on YouTube, so you can have a look on the YouTube channel. And by the end of it, I'll be able to send the slides out, and it hopefully be quite a extensive general surgery lecture slides. How do people find the use of guidelines, things like that? I know it's not very interesting, but it's quite useful for exams, I think. But what do you guys think? Helpful, good, okay. Everything I do is from the NICE guidance or BMJ best practice or like BMJ websites or like the Merseyside guidelines. So I'm trying to use your guidelines to aim most of that, and it's all up to date. So if you use anything in here, you'll be able to argue in your exam that you're correct, which is what you should be doing really. Okay, how about frequency? Do we find it okay once a week, or because I know you had phrases on Thursday, so it was nice, something different. Is once a week okay for this, or just keep it going, rolling on till your exams?